Good morning, everyone. So today I have summarized the small for gestation age guideline for you. So this is a green top guideline, quite an important one to understand, not only for your exams, but also for your clinical practice. Now, I found this guideline very difficult to revise because firstly, it's such a long guideline that you completely lose focus whilst reading it. So summarizing it and simplifying the content really helps in maintaining concentration and trying to remember the salient points for your exam. So birth weight of less than 10th centile is defined to be a small for gestation age infant. So there are different causes of a SGA baby. So they can be fetal, which are, it could be that it's normal for that baby, so it's constitutionally small. It could be non-placental mediated growth restriction, like for example, structural or chromosomal anomalies, or it could be placenta-mediated growth restriction. There can be maternal factors like low pre-pregnancy weight, undernutrition, substance misuse, or severe anemia. There can be medical conditions that can affect the placental implantation and vasculature, which then affect the transfer of nutrients from the placenta to the baby in conditions like preeclampsia, autoimmune disease, thrombophilias, renal disease, diabetes, and essential hypertension. So at booking, risk factors for SGA fetuses should be identified so the right pathway can be instilled for these mothers to help these babies. Now, I will be going through a flowchart where we'll be discussing what are the important risk factors that you want to be looking for in the history, and then what does those risk factors mean in terms of follow-up. So there's a major risk factor, then referral for serial ultrasound for fetal growth and umbilical artery Doppler from 26 to 28 weeks of pregnancy is recommended. So the word serial is important, which means that you started off around that time of the pregnancy and then carry it on every 2 weeks or every 4 weeks, depending on measurements. If there is equal to or more than 3 minor risk factors, then the patient is referred to have a uterine artery Doppler at 20 to 24 weeks. Having a previous SGA baby increases risk of having another one by twofold. So a low level of PAP-A, which is less than 0.415 MOM in the first trimester, is a major risk factor for delivery of SGA infant. Uterine artery Dopplers, now if they are abnormal at 20 to 24 weeks, and even if they do normalize later on in the pregnancy, it's still indicative of having SGA baby. So they shouldn't really be repeated. So with women with abnormal uterine artery Dopplers at 20 to 24 weeks and or notching should be referred for serial ultrasound scan for growth and umbilical artery Doppler at 26 to 28 weeks of pregnancy. Women who have normal uterine artery Doppler do not require any serial scans, but they should be offered a scan for growth and umbilical artery Doppler in the 3rd trimester. So this slide is very important, and I'm also going to be going through this slide in the flowchart, which just make it a bit more simplified and easy to understand. So don't worry if you haven't followed it here. If there is fetal echogenic bowel, then serial ultrasound scan for growth and umbilical artery Doppler is recommended. And this is normally picked up at the 20-week scan. Abdominal palpation has limited accuracy for prediction of SGA infant. However, if there is measurement of symphysis fundal height, which has picked up a baby which is plotting less than the 10th centile, or is showing slow or static growth, then the mother should be referred for a ultrasound scan. The serial measurements for symphysis fundal height should be plotted on a customized growth chart, so that the accuracy of prediction of SGA infants goes up. Also, they should be started from 24 weeks. If in patients who have BMI over 35 or large fibroids or polyhydramnios, and which will mean that um, measurement of the symphysis fundal height is going to be inaccurate, then these patients should have serial scans for measurement of fetal growth. So what is the optimum method of diagnosing as SGA infant and fetal growth restriction? So that's abdominal circumference or estimated fetal weight of less than 10th centile. What investigations are indicated when there is SGA? So severe SGA at 18 to 20 weeks, that means you should refer the patient for a fetal medicine specialist. Karyotyping is recommended for fetuses who have severe SGA less than 23 weeks to check for any chromosomal anomalies. Serological screening for CMV and toxoplasmosis infection is also recommended in severe SGA. Syphilis and malaria screening is also recommended in high-risk population. Uterine artery Doppler has limited accuracy in predicting adverse outcomes in SGA infants diagnosed during the 3rd trimester. What interventions should be considered in the prevention of a SGA fetus or neonate? So aspirin is recommended for patients with high risk of preeclampsia, and that should be started less than 16 weeks. Women should have promotion to help them stop smoking, because that really helps prevent SGA. Antithrombotic therapy has shown evidence to help prevent SGA. However, this is not currently used in the clinical practice as there's still insufficient data about its adverse effects. What interventions should be considered in the preterm SGA fetus? So somebody who is between 24 and 35 plus 6 weeks, you want to be giving them steroids if they are a SGA baby. What is the optimal method and frequency of fetal surveillance in an SGA infant, and what are the optimal tests to time delivery? So, umbilical artery Doppler is the primary surveillance tool in the SGA infant. Umbilical artery Doppler, if it's normal, then it should be repeated every 14 days. If it's abnormal, then you do it twice weekly. As long as there is end diastolic flow is present. It should be done daily if there is absent or reversed end diastolic flow. So I repeat that again. So umbilical artery Doppler if it's abnormal, but there is presence of end diastolic velocity, then it should only be repeated twice weekly. But if there is absent or reversed end diastolic flow, then it should be done daily. CTG is recommended. Within the CTG, it's the short-term variation that you want to be looking for the SGA fetuses, and that's normally calculated on the computerized version of the CTG, the Dawes-Redman. Amniotic fluid volume, when it's measured, the single deepest vertical pocket is recommended for SGA babies. Middle cerebral artery. So in the preterm SGA fetus, middle cerebral artery has limited accuracy. Adverse outcome, again, and also in prediction of adverse outcomes, and it should not be used to time delivery. So in preterm SGA babies, MCA is not of a lot of benefit. In the term SGA fetus with normal umbilical artery Doppler, an abnormal MCA has moderate prediction of acidosis at birth and should be used to time delivery. Ductus venosus Doppler has moderate prediction for acidemia and adverse outcome and should be used for surveillance in the preterm SGA baby with abnormal umbilical artery Doppler and used to time delivery. So, if there's SGA in a term baby with normal umbilical artery Doppler, then an abnormal MCA should help to time delivery. In a preterm SGA baby with abnormal umbilical artery Doppler, ductus venosus Doppler will help to time delivery. What is the optimal gestation to deliver the SGA fetus? So if baby is preterm SGA, so that's less than 32 weeks, with umbilical artery Doppler showing absent or reversed end diastolic velocity, then delivery with with ductus venosus Doppler if it's abnormal or UV pulsations appear. So in a preterm baby, if DV ductus venosus Doppler is abnormal or UV pulsations appear, then delivery is recommended. Even when venous Doppler is normal, delivery should be considered between 30 to 32 weeks of gestation. If MCA Doppler is abnormal, delivery should be recommended no later than 37 weeks. That's all in preterm babies. If there is SGA in more than 32 weeks, so babies over 32 weeks, but abnormal umbilical artery Doppler, then delivery no later than 37 weeks is recommended. If a baby has SGA over 32 weeks, but umbilical artery Doppler is normal, then delivery should be offered at 37 weeks of gestation, and a senior clinician should be involved in the decision making. How should the SGA fetus be delivered? If there is SGA with umbilical artery absent or reversed end diastolic velocity, then a caesarean section is recommended. If there is SGA with normal umbilical artery Doppler or with abnormal umbilical artery but end diastolic velocity present, then induction of labor is recommended. Continuous fetal monitoring is recommended in labor. So for people who've gone into spontaneous labor with SGA fetus, early admission for continuous monitoring of the baby is recommended. So this was the flowchart that I mentioned earlier. So this says booking assessment is done in first trimester, minor risk factors like maternal age over equal to over 35. IVF singleton pregnancy, nulliparity, BMI less than 20, BMI 25 to 34.9, smoker 1 to 10 cigarettes per day, low fruit intake, previous preeclampsia, pregnancy interval less than 6 months, pregnancy interval greater than 60 months. So this is minor risk factors. Now if there's 3 or more of these risk factors, then reassess at 20 weeks for PAP-A and fetal echogenic bowel. If there is just the presence of these, then 3 or more minor risk factors means that the patient will have a uterine artery Doppler at 20 to 24 weeks, and if this is normal, then assessment of fetal size and umbilical artery Doppler in the 3rd trimester. If this is abnormal, then serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. Okay. Now, if there are major risk factors present, so maternal age over 40, smoker greater than 11 cigarettes per day, paternal SGA, cocaine user, daily vigorous exercise, previous SGA baby, previous stillbirth, maternal SGA, chronic hypertension, diabetes with vascular disease, renal impairment, antiphospholipid syndrome, heavy bleeding, similar to periods, PAP-A less than 0.4 mean of median. So if there's only one risk factor in all of this, then then basically serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. Now, for women who are unsuitable for symphysis fundal height measurement, so as we said previously, if they've got large fibroids or the BMI over 35, then basically they should have serial measurements of fetal size and umbilical artery Doppler from 26 to 28 weeks. Okay, so this is a chart which again summarizes what to do with a small for gestation age fetus. So if the symphysis fundal height picks up a measurement of less than 10 centile, or there is high risk of SGA based on the history, then basically the women should be referred for a scan. Now, if on the scan there is abdominal circumference or estimated fetal weight of less than 10 centile, then this confirms SGA. If uterine artery Doppler is normal, then repeat ultrasound should be done every 2 weeks, and it should assess an abdominal circumference, estimated fetal weight, uterine artery Doppler, MCA Doppler only after 32 weeks, because as we said, MCA Doppler is not too good less than 32 weeks. Now, if this is all on these measurements, if the PI or the RI is greater than 2 standard deviation and EDV is present, then repeat ultrasound weekly for abdominal circumference and estimated fetal weight, twice weekly for uterine artery Doppler. Okay. Now going down to if uterine artery Doppler was absent, reverse, and diastolic velocity, then repeat abdominal circumference and estimated fetal weight weekly, but daily uterine artery Dopplers, ductus venosus Dopplers, and CTG as well. So, delivery. Delivery is recommended before 32 weeks after steroids if abnormal ductus venosus Doppler and or CTG concerns. Recommend delivery by 32 weeks after steroids. Consider delivery at 32 to 32 weeks even when DV Doppler is normal. Okay. Now, if you could go back to the first flowchart, so where it says uterine artery Doppler is normal, repeat scan every 2 weeks, offer delivery by 37 weeks with involvement of a senior clinician, recommend delivery by 37 weeks if MCA Doppler is abnormal, consider delivery over 34 weeks if static growth over 3 weeks. Recommend steroids if delivery is by cesarean section. Now, where we said that these Doppler were abnormal, we said repeat ultrasound weekly and twice weekly uterine artery Dopplers. Delivery recommended by 37 weeks. Consider steroids if delivery by cesarean section. Consider delivery greater than 34 weeks if static growth over 3 weeks. Recommend steroids if delivery by cesarean section. Okay, so this was the SGA guideline summarized for you. I hope you've found this useful, and if you did, then please give this video a thumbs up and subscribe to my channel. Also share this video with any of your colleagues who are struggling with this guideline or about to sit the exam and will find this useful. I really do feel that sometimes by someone talking through the guideline with you, it does help reinforce things for you and helps to remember things better for you. Thanks for listening.